Dr. Resneck, very generally, would you start us off by outlining the need for health equity and racial justice, and particularly the American Medical Association's role in that, as well as yours as its president?
Great. Well, thanks so much for having me today to talk about this important topic. I just want to start by saying I approach this topic with some humility. I certainly have a better understanding of racism and healthcare and health equity than I once did, but there's a lot I still don't know, and I'm sure there are many viewers today who have more personal experience to draw on than I do. We as physicians and the American Medical Association see overwhelming evidence of really appalling health inequities for our Black patients, brown patients, indigenous populations, and LGBTQ patients as well. We really saw it with COVID, as we have for years with hypertension and diabetes and many other chronic diseases we treat. And we know that systemic racism has played a role in this. So we really feel like, as part of our ethical code and our moral responsibility as physicians, that we have to address them.
Fantastic. And Dr. Taylor, as a professor of dermatology and chair for diversity, would you bring us deeper into what you view as the largest systematic failures and maybe common misinformation in dermatologic treatments for people of color?
Well, again, thank you very much for having me. There are many systematic failures, in my opinion, as it relates to dermatology. First is access to care. There are many barriers to care for patients from underserved communities. In my specialty, in particular in dermatology, there are real gaps in regard to the diagnosis and treatment of disorders that occur in people of color. There are gaps in terms of cultural competency and humility in terms of those diseases. And, some of that relates to the paucity of images in our textbooks as well as our publications. One other thing I'm going to point out is the gap in people of color enrolling in clinical trials. So for many diseases, we don't have that data in regard to safety and efficacy of their ability to benefit from certain medications. So those are just a few I want to highlight.
And what are some of the hurdles of getting them into trials?
Well, it's a complex situation. So I think, number one, it's critically important that we have clinical trial sites that have people of diverse backgrounds, and then they will have patient populations from diverse backgrounds. So that's number one. Number two, those diverse sites have an ability to build trust with those patient populations. So I think that's critically important. It behooves pharmaceutical companies, for example, to ensure that they select sites that are diverse. And I think that is improving. It's not where it should be at this point.
Fantastic. Dr. Resneck, would you give us the background of how and when organized medicine became more deeply engaged in addressing racial inequities? And how does that look in application at large, complex organizations?
Well, I should probably first say, the AMA is an organization that's been around for 175 years. So the first thing that we've been doing is actually reckoning with our own history, because as we look back, organized medicine and the AMA actually are responsible for some harm in this space. We had past leaders, for example, J. Marion Sims, who really is considered the father of OBGYN in this country, but who did experiments on slaves without anesthesia. We have the Flexner Report in the early 20th century, which the AMA had some role in initiating, that reformed medical education, but in the process actually closed down a number of historically Black medical schools at a time when Black students were unable to get into and train at other medical schools. And it wasn't even until the late 1960s that we ensured that state medical associations who came to our AMA House of Delegates actually were inclusive and didn't exclude certain races. So we've got a lot of history that we have been publicly reckoning with in order to rebuild trust with marginalized and minoritized communities. In 2008, the AMA issued an apology for that history of racism. And in 2019, based on policy from our House of Delegates, which represents physicians from around the country, we created a Center for Health Equity, hired Aletha Maybank, who's been doing a fantastic job as the first leader of that center. Its work is really grounded in science. It's based on policy from our House of Delegates. And when it was created, I really felt like ultimately it would be successful if we reach a point where your zip code or the color of your skin don't impact your health outcomes as they unfortunately do today. But in the shorter or medium term, I felt like it would be successful when we saw its work not siloed in one part of our organization, but actually impacting everything we do in all of our business units. And I'm really optimistic that that's exactly what I'm seeing. So when we think about what's going on, for example, in our group that handles chronic disease, we have efforts meeting populations where they are. We have a Release the Pressure campaign, for example, that is focused on hypertension in Black women in this country, which is a problem we've partnered with Essence and other groups to address that. Our group that works on medical education is focused on making sure that we have a pipeline of future physicians that represents the diversity of patients that we take care of. We've been convening medical educators and medical schools around the country to rethink curricula so that we actually train another generation of medical students and future physicians who can go out and address inequities in their practices and their communities. Our litigation center at the AMA is working to block discriminatory laws affecting immigrants and LGBTQ populations and making sure that there's broad access to reproductive health. Our advocacy team is making sure that all populations have access to telemedicine. We actually have an innovation group that's focused on artificial intelligence and digital health and making sure, as we think about equity in those spaces, that they are deployed in ways that mitigate and get rid of health inequities instead of worsening them. I could go on and on and on, but I'm really impressed that this work has really not only been the center of our Center for Health Equity and the 50 employees that we now have working there, but across the organization is taking root.
And how do you encourage others to follow that lead?
I've actually been impressed to see physician groups across specialties and across states invest in similar work. I think as we have more and more evidence of inequities and outcomes in healthcare, and Susan is here today as a fellow dermatologist and thinking about what the American Academy of Dermatology is doing. This is really all of our work, and it's all of our responsibility to focus on it. So I've been pleased with what I've seen.
Dr. Taylor, what do you view as the top 3 practices to combat inequities in dermatology?
Well, I think number one, it's critically important that the physicians' population reflect our overall U.S. population. And by that, I mean physicians of African descent make up about 3% of our dermatology workforce, for example, as compared to 13% of our population. Our Latinx physicians are about 4.2% of dermatologists in this country, as compared to 18% in our population. And similar trends with American Indian, Alaska Natives as well. This is not just numbers for dermatology, but for many medical specialties. So number one is improving those numbers, training those individuals who we call underrepresented in medicine. I think that's critically important to solving some of these gaps. Number two, we spoke a little bit about clinical trials. I think that is critically important, that we enroll patients in proportion to their proportion in our U.S. population, for example. Building that trust, reaching out to those particular sites, and making sure that for every single medication or device that's approved by the FDA here in the United States, that there's adequate testing in regard to safety as well as efficacy. And I think training is also very important. In my specialty of dermatology, all dermatologists must be able to diagnose and treat in a culturally competent way all patients, no matter what their race, no matter what their ethnicity, no matter what their socioeconomic status, for example. So that training, be it for medical students or medical or dermatology residents, or for attending physicians, I think is critically important in reversing and closing these gaps.
Those are some impactful numbers. What do you think is the best way to target, getting more physicians in the door initially? Is it getting them? Is there a lack of application? Are they dropping out? How do we get more of them to become dermatologists and other fields as well?
Yeah, well, it's a very complex problem, and it's the approach to solving the problem must start with students in elementary school and middle school. So it's about building the pipeline, going out to elementary schools, middle schools, high schools, introducing those students to STEM, supporting curricula regarding STEM. And then with these young people in college and medical school, again, exposing them to my specialty of dermatology, providing research opportunities, for example, having our medical students reach back to our college students who can then reach back to our middle school students. So it's really developing an important and robust pipeline. And that's a responsibility of all physicians, not just physicians, for example, in academic medicine, but physicians across the board.
Fantastic. And so, Dr. Resneck, to conclude this great discussion, would you tell us about how you see the future? What is in the pipeline, and what can the profession continue to do to advance health equity and access to care?
Well, first, I really want to reinforce Dr. Taylor's great comments about the pipeline of future physicians and how important it is to have a workforce that really does more closely resemble the populations we serve. We actually have data and evidence that doing so improves care and generates better health outcomes. Medical students, for example, who learn alongside peers who are diverse, end up being better able to be culturally competent and to take care of diverse populations and improve health outcomes. We actually had an article in JAMA Dermatology, a journal just this week, that dermatology continues to be a specialty that has a long way to go, as many others do, in achieving this. We've been disheartened, actually, that the Supreme Court, for the third time in a decade, heard arguments this month seeking to ban holistic review. And it's really important that those of us in medical education are able to look at the breadth of every candidate and what they bring, including the diversity of those candidates. And so we filed an amicus brief in support of Harvard and the University of North Carolina in that case, and their ability to continue to do race-conscious admission practices. There are a lot of other things that we can do. Dr. Taylor mentioned reaching back to elementary and secondary education as a piece of this. We also need to expand the number of residency training positions that are available. Those are largely funded by the federal government through the Medicare program. And in order to have more physicians, we need those slots expanded. There are also cost barriers. We have medical students graduating with $200,000 and $300,000 of debt in this era, and that doesn't help us to bring populations who, again, have been just historically excluded and marginalized from medical education into the pipeline. And we need to build better pathways and mentoring, as Dr. Taylor alluded to make sure that we help open the door and bring people through it. Again, we're working in medical education to make sure that the curricula are designed once we attract people to medical school and have them there so that they're able to take care of diverse populations in the future. And then access to care is really important because we know that a number of the limitations on access to care in patients who can't get insurance and other things that block access to care do tend to fall hardest on marginalized and historically minoritized populations. So as we as physicians continue to advocate for improved insurance coverage, for example, around the country, that is a focus. And then finally, I would just say, as physicians traditionally We sort of in our training have been very focused on when patients show up in our offices already sick or already with a chronic disease, sort of treating what's in front of us. And I think as we have looked more and more at what leads to health inequities, we're increasingly focused on what we call pushing upstream, which is thinking about those things in society that actually affect and are determinants of health outcomes. So whether it's housing insecurity or food insecurity or differences in educational access or access to transportation, all those things ultimately are affecting the health of the populations we serve. And so we've realized that even though they're traditionally not things that maybe we spoke up about as physicians, that they're very much in our lane, and it very much is our responsibility because those things all affect health outcomes so much to speak up when policy is being made so that we can reduce the impact of systemic racism and actually push upstream to improve the health of the nation.
Wonderful. And Dr. Taylor, do you have any concluding remarks that you'd like to add?
I do indeed. I think the future is bright. I am very hopeful that we are going to be able to impact these gaps that we've talked about for the last several minutes. Many professional organizations, those within dermatology as well as umbrella organizations like the AMA, are committed to ensuring that all patients receive the care that they deserve, that they receive excellence in care. And collectively, as we work together on this problem, we'll be able to solve it. So that's why I say I'm hopeful and our future is bright.
Thank you for leaving us on that optimistic note. It was a pleasure speaking with you both today.
Thank you.
Thanks so much for having us.